All right. Welcome back to NeuroClarity, the podcast where neurology becomes clear, one neuron at a time. I am your host, Onowori Victor, and today we are diving deep into four power-packed, board-ready questions from Chapter 2 of Ching and Cheng's comprehensive review of clinical neurology. These questions explore atrial fibrillation stroke prevention, vasculitis of the CNS, RCVS, and carotid revascularization strategies. This episode is for you, the busy medical student, the tired but determined resident, or the curious clinician looking to sharpen their vascular neurology edge. That being said, let's begin. Question 70. A 69-year-old woman with history of hypertension, diabetes mellitus presented with transient ischemic attack and was found to have atrial fibrillation. The patient declined warfarin therapy but would like to start one of the non-vitamin K antagonist oral anticoagulants. Regarding these agents, which of the following is correct? A. Dabigatran is cleared by the liver and adjustments are not required in patients with renal impairment. B. Apixaban is a factor 10A inhibitor which has been shown to have lower risk of intracranial hemorrhage as compared to warfarin. C. Rivaroxaban is a direct thrombin inhibitor administered twice daily. D. Dabigatran has a very short half-life of less than 10 hours with high oral bioavailability. And E. Direct thrombin inhibitors and factor 10A inhibitors have to be monitored by coagulation studies with a target INR of 2 to 3. What do you think? First, let us clarify the landscape of oral anticoagulants for valvular atrial fibrillation. The famous warfarin has long been the standard for stroke prevention in atrial fibrillation, but it's a tough drug to manage. You need to frequently check the INR. You need to note that it has a narrow therapeutic window and it has a tone of drug to food interaction. And that's where the non-vitamin K antagonist oral anticoagulants come in, the NOAC or the DOAC, the direct oral anticoagulants. There are three of them that you should be very familiar with, and they include Dabigatran, Rivaroxaban, and Apixaban. Let us talk about Dabigatran. Dabigatran is a direct thrombin inhibitor and it's available as a prodrug which is converted to its active form. It has a very poor oral bioavailability and in fact it is coated with tartaric acid to help enhance its absorption. 80% of the drug is cleared by the kidneys and that means that the renal function guides its dosing. It has a half-life of 14 to 17 hours and the key side effects include dyspepsia and GI bleeding. It has a reversal agent and in fact it is the only DOAC or NOAC that has a reversal agent. That reversal agent is idarucizumab. We have Rivaroxaban and Rivaroxaban is a factor 10A inhibitor. It is given once daily with food and 2/3 of it is cleared by the liver while 1/3 is cleared by the kidney. It has a half-life of 5 to 9 hours and you do not need INR monitoring. Apixaban is also a factor 10A inhibitor and it is dosed twice daily. It is metabolized in the liver via the cytochrome P3A4 with 25% of it being cleared by the kidneys. It has been shown to reduce the risk of major bleeding, particularly intracranial hemorrhage compared to warfarin. It has a superior stroke prevention efficacy as shown in the Aristotle trial. Now, there's something I want us to take from this. None of the NOACs require INR monitoring, unlike warfarin, but they are not all the same. They have different renal clearance, different side effects, different dosing, and different strategies required. That being said, let's get back to our question. Option A. Dabigatran is cleared by the liver and adjustments are not required in patients with renal impairment, and that's wrong. Remember we said Dabigatran is 80% cleared by the kidneys and not just the liver, and those adjustments is required in renal impairment. In fact, it is contraindicated in severe renal failure, that is, a creatinine clearance of less than 15 ml per minute. Option C says Rivaroxaban is a direct thrombin inhibitor administered twice daily, and that is wrong. Rivaroxaban is a factor 10A inhibitor and it is not a thrombin inhibitor. It is typically dosed once a day and not twice a day, especially at a 20 milligram dosage for atrial fibrillation. Option D says Dabigatran has a very short half-life of less than 10 hours with a high oral bioavailability, and that is false. Dabigatran's half-life is actually 14 to 17 hours and not less than 10 hours. It has a poor oral bioavailability, about 6%, which is why it is coated with tartaric acid to improve absorption. Option E says diarectromy inhibitors and factor 10A inhibitors have to be monitored by coagulation studies with a target INR of 2 to 3. And again, that is wrong. One of the key advantages of DOACs or NOACs is that they do not require INR monitoring, and unlike warfarin, NOACs have predictable pharmacokinetics. Let's get back to option B. Apixaban is a factor 10A inhibitor which has been shown to lower the risk of intracranial hemorrhage as compared to warfarin, and that is true. This was demonstrated in the Aristotle trial. That being said, our answer is B. Next question. Question 71. A 50-year-old man with history of recurrent ischemic strokes undergoes a cerebral angiogram which demonstrates area of narrowing and dilatation bilaterally. A diagnosis of vasculitis of the central nervous system is considered. Which of the following is correct regarding vasculitis of the central nervous system? A. CSF analysis is not necessary and should not be obtained in every patient with suspicion for this diagnosis. B. Cerebral angiogram has high specificity and is a gold standard to make the diagnosis. C. A definite diagnosis requires brain biopsy evidence of vessel wall inflammation. D. Brain biopsy is highly sensitive for the diagnosis of this condition. E. Thunderclap headache is a typical presentation of primary angiitis of the central nervous system. What do you think? CNS vasculitis is tricky. It mimics, it masquerades, and it is notoriously hard to diagnose. There are two broad types, which includes the primary angiitis of the central nervous system, aka PACNS, and the second one is called secondary CNS vasculitis. Primary angiitis of the central nervous system is idiopathic. It affects the parenchymal and leptomeningeal arteries and typically presents at age 40 to 60. The symptoms include chronic headache, cognitive decline, focal deficit, and stroke, and thunderclap headache is rare, and this helps to differentiate it from RCVS, reversible vasoconstriction syndrome. Secondary CNS vasculitis, on the other hand, is due to systemic conditions like lupus, PAN, which is polyarthritis nodosa, and Wegener's syndrome. Infections including HIV and syphilis can also cause it, can be drug-induced, and it can be malignancy related. There are certain diagnostic essentials that you should be aware of, and they include an MRI of the brain, which shows infarct, calonidium-enhancing lesions, and non-specifying white matter changes. CNS analysis is generally abnormal in most primary angiitis of the central nervous system cases. You tend to see increased protein and increased WBC count, that is white blood cell count. CSF analysis is essential to rule out mimics. Angiography tends to see bleeding patterns, and this is not specific because it is also seen in atherosclerosis, RCVS, and vasospasm. Brain biopsy is the gold standard for diagnosis. It confirms vessel wall inflammation, but that's a low sensitivity due to sampling error. That being said, let's get back to our question. Option A says CNS analysis is not necessary and should not be obtained in every patient with suspicion for this diagnosis, and that is wrong. Like we said before, CNS analysis is essential in evaluating suspected CNS vasculitis. It helps us to exclude mimics including infection and malignancy. It is also worthy to note that CNS analysis is usually abnormal in most cases of primary angiitis of the central nervous system, and you tend to see high WBCs and high protein. Option B says cerebral angiogram has high specificity and is the gold standard to make the diagnosis, and that's false. Cerebral angiogram is sensitive, but it is not specific. Bleeding can be seen in mimics like RCVS, atherosclerosis, and vasospasm, and it is not the gold standard. The gold standard is brain biopsy. Option D says brain biopsy is highly sensitive for diagnosing this condition, and that is wrong. Even though brain biopsy is the gold standard, it is not highly sensitive. It has a low sensitivity due to sampling error and focal disease distribution. Option E says thunderclap headache is a typical presentation of primary angiitis of the central nervous system, and that is wrong. Thunderclap headache, like we said, is rare in primary angiitis of the central nervous system, but is typical of reversible cerebral vasoconstriction syndrome. Primary angiitis of the CNS usually presents with chronic insidious headache. So, our option, like we've said twice now, is C. A definite diagnosis requires brain biopsy evidence of vessel wall inflammation. Next question. Question 72. A 40-year-old woman developed a sudden onset of severe headache with peak within seconds, improving within a few hours. She had nausea and vomiting, but no other neurologic deficits. She reported taking amphetamines, and brain CT showed a small cortical subarachnoid hemorrhage in the right hemispheric convexity. A cerebral angiogram was obtained showing bleeding in the MCA, ACA, and PCA branches bilaterally, but no aneurysms or vascular malformations. CSF analysis did not show evidence of inflammation. Her headache persisted, but over the next week, her symptoms resolved, and on follow-up visits at 3 months, she was doing well with no reoccurrence. Which of the following is correct regarding this condition? A. Findings on cerebral angiography resolved within 12 weeks. B. Brain biopsy is indicated in all cases demonstrating vessel wall inflammation. C. It is always benign and not associated with stroke or intraparenchymal hemorrhage. D. More common in men than in women. And E. Steroids are recommended and their use improves outcomes. What do you think? This is a typical RCVS, reversible cerebral vasoconstriction syndrome. RCVS is all about transient reversible vasospasm affecting cerebral arteries. It has classic clinical features which includes thunderclap headache, which is usually sudden and peaks within seconds, may reoccur over 1 to 4 weeks, and may cause nausea, photophobia, and vomiting. Patients may have transient neurological deficits and may even have seizures. On imaging, CT or MRI may show cortical subarachnoid hemorrhage, especially convexity bleed, like we saw in our patient, ischemic stroke, or intracranial hemorrhage in severe cases. Angiography generally shows bleeding patterns in the MCA, ACA, and PCA branches, and these changes resolve within 12 weeks, hence the name reversible cerebral vasoconstriction syndrome. How do you distinguish it from CNS vasculitis? RCVS has normal or near normal CSF. Primary angiitis of the CNS has abnormal CSF and it is insidious in course. Reversible vasoconstriction syndrome generally resolves while vasculitis persists without treatment, and biopsy in RCVS is not needed as it shows no inflammation. RCVS has certain triggers which includes drugs like amphetamine, tryptans, and cocaine, activities like sex, exercise, and valsalva maneuvers, postpartum state like eclampsia, and is also linked to PRES, which is posterior reversible encephalopathy syndrome. Management includes supportive care, calcium channel blockers like nimodipine, and avoiding steroids because this may actually worsen the condition. That being said, let's go back to our question. Option B says brain biopsy is indicated in all cases demonstrating vessel wall inflammation, and like we said before, that is false. Biopsy is not indicated in a typical RCVS because it will show no inflammation, and that's because RCVS is a non-inflammatory vasoconstrictive process. Option C says it is always benign and not associated with stroke or intraparenchymal hemorrhage, and that is false. We just said that RCVS can be complicated by stroke, intracranial hemorrhage, or cortical subarachnoid hemorrhage. And while it is often self-limiting, it is not always benign. Option D says more common in men than in women, and that is false. RCVS is more common in women, especially middle-aged women, and in postpartum or vasoactive drug exposure cases. So, back to option A, findings on cerebral angiography resolves within 12 weeks, and that is true. Remember, that is why it is called RCVS, reversible cerebral vasoconstriction syndrome. So, A is our correct answer. Next question. Question 73. Which of the following is correct regarding revascularization therapies for carotid stenosis? A. Long-term stroke rate is significantly lower after carotid stenting as compared to CEA. B. CEA is the treatment of choice in patients with carotid stenosis and previous radical neck surgery and radiation. Periprocedural stroke risk is lower with carotid stenting as compared to CEA. D. CEA is the treatment of choice in patients with carotid stenosis and contralateral carotid occlusion. And E. Carotid stenting is associated with lower risk of myocardial infarction as compared to CEA. What do you think? Patients with significant carotid artery stenosis may benefit from carotid endarterectomy or carotid artery stenting. Let us talk about this. Carotid endarterectomy, also known as CEA, is a surgical procedure that involves making an incision in the neck to open the carotid artery and remove atherosclerotic plaque causing stenosis. The goal is to restore normal blood flow to the brain and reduce the risk of stroke, and anesthesia is typically employed. We usually use the general anesthesia, although it can also be done locally. It is done for older patients, patients with favorable neck anatomy, and those who have low surgical or anesthetic risks. The advantage is that it is very effective for stroke prevention in properly selected patients. It is a long-standing and it's a well-studied technique. The drawbacks include the fact that one, you're going to have a surgical incision and it may have wound complications. There's an increased risk of cranial nerve injury, and there's also a risk of myocardial infarction due to perioperative cardiac stress. Carotid artery stenting, on the other hand, is a minimally invasive endovascular procedure that is done via catheter, usually from femoral or radial access, where a balloon or a stent are used to dilate the narrowed carotid artery and to keep it open. The goal is the same as the carotid endarterectomy, to prevent strokes by restoring blood flow. It is best for patients who have high surgical risks, those with hostile neck anatomy, like those who have had prior radiation, surgery, or high carotid bifurcation, or those who have significant cardiac or pulmonary disease. The advantages include one, it is less invasive, so there is no surgical incision. It can be done under local anesthesia and it has a faster recovery time. Basically, you bypass general anesthesia. The drawback is that it has a higher risk of periprocedural stroke due to manipulation of carotid artery during stent deployment. Now, stroke is higher in carotid artery stenosis, and the main reason is due to embolization of plaque or thrombus during the procedure. In carotid artery stenosis, instruments like wires, balloon, and stents are passed through the aortic arc up into the carotid artery, often crossing the stenotic lesion. Now, this can actually discharge atherosclerotic debris, which may travel distally into the brain, causing perioperative embolic stroke. Although embolic protection devices like filters or distal occlusion balloons are used, they are not 100% effective, and additionally, manipulation of tortuous arteries in older patients can increase the risk of stroke. There's an extra nuance. Carotid artery stenosis outcomes are worse in patients older than 70, largely because of more extensive atherosclerosis and less flexible vasculature, making stent navigation riskier. Now, for carotid endarterectomy, the MI risk is higher, and the main reason is due to surgical stress and anesthesia-related cardiac burden. Carotid endarterectomy is a surgical procedure often under general anesthesia, which can strain the cardiovascular system. Older patients, especially those with pre-existing coronary artery disease, are at higher risk of perioperative myocardial infarction from hemodynamic fluctuation during surgery, increased myocardial demand, and possible intraoperative ischemia. So, even though patients are optimized preoperatively, some still experience silent or overt MIs during or shortly after carotid endarterectomy, especially if they have underdiagnosed coronary disease. What does the trial say? The Safriel trial compared CEA and CAS in high-risk surgical patients, and they saw that they had similar long-term outcome. However, there was an initial lower stroke or death risk in the stenting group. Now, the CREST trial, on the other hand, randomized both symptomatic and asymptomatic patients. They saw no difference in long-term stroke prevention and higher stroke rates with those who had stenting, higher MI rates in those who had CEA, and it was shown that age matters. Carotid artery stenting is better in patients less than 70 years, and CEA is better in patients more than 70 years. Who gets what? CEA is preferred when you have low surgical risks, favorable anatomy, and older age group. And CAS is preferred when you have prior neck radiation, surgery, and difficult anatomy. If you have a patient who is younger or a patient who has a high surgical or anesthetic risk, CAS is preferred. What's our clinical takeaway? Stenting saves the heart and endarterectomy protects the brain. This patient's risk profile decides the lane. So, back to our question. Option A, long-term stroke rate is significantly lower after carotid stenting as compared to CEA, and that is wrong. Long-term stroke rates are similar, but CAS has higher perioperative stroke rates, especially in older patients. Option B, CEA is the treatment of choice in patients with carotid stenosis and previous radical neck surgery and radiation, and that is wrong. CAS is preferred in patients with prior neck surgery, radiation, or hostile neck anatomy. CEA in such cases carries higher surgical risks. Option C, periprocedural stroke risk is lower with carotid stenting as compared to CEA, and that is wrong. It is actually the opposite. CAS has a higher stroke risk and CEA has a higher MI risk. Option D, CEA is the treatment of choice in patients with carotid stenosis and contralateral carotid occlusion, and that is false. CAS is often preferred in these cases to reduce the risk of hypoperfusion or embolization during open surgery. So, our option is E. Carotid stenting is associated with lower rates of myocardial infarction compared to CEA. Vascular neurology is all about NOACs. The right drug, the right vessel, and the right timing can change everything. Thanks for tuning into NeuroClarity. If this has helped solidify your understanding, share it with your study group, tag us online, or leave a review. Until next time, keep your brain sharp and keep your questions sharper. Stay clear and bye for now.